This podcast is a Christian view of the controversial subject of gender identity.
Welcome, everybody, to this latest episode of Stars, Cells, and God. This is the podcast where we explore how the latest discoveries in science provide evidence for God's existence, the reliability of Scripture, and the Christian worldview. My name is Rana. I'm a biochemist and a Christian apologist, and I work for an organization called Reasons to Believe. Reasons to Believe is the organization that sponsors this podcast, thanks to the generous gifts and donations of viewers and listeners like you. If you want to know more about Reasons to Believe and how you can support this podcast, go to our website, reasons.org. Also, you can follow us on social media, RTB_official. And then finally, go to our YouTube channel, Reasons to Believe, and subscribe. There you can gain access to all kinds of great content that address science, faith questions. And while you're there, use the notification button so that you can be alerted the next time a new episode of Stars, Cells, and God drops. I have the pleasure of being joined today by Dr. Christina Cirucci, who is trained as a medical doctor, and her specialization is obstetrics and gynecology. And we're going to be talking about a very critical issue today, namely the effectiveness and the safety of puberty blockers. Chris, thanks so much for being here with us today.
Thanks so much for having me, Fuzz. It's great to be here. This is an important topic.
Yeah, it is. It definitely is. And this is really part of a larger project that we have underway here at Reasons to Believe, where we are engaging issues related to gender identity. And Chris, you headed up a team of medical doctors, a philosopher, a biblical scholar, who did a deep dive over the course of the last year, going into the relevant literature and providing responses to about 10 or 15 critical questions relating to gender identity. And so we're grateful for you to do that, the fact that you did that you headed up that team. And we're now in the process of releasing some of that content for public consumption. And so this is part of a broader project where we are looking at how does the medical information, how does the science related to gender-affirming care, related to gender identity, relate to the biblical perspective on gender and human nature. So Chris, again, thanks for being here. And just so people can get a chance to know you a little bit, maybe you could give us a quick introduction about who you are and what your area of expertise is and your interests.
Yes, thank you so much, Fuzz. Thanks for having me on this podcast. As you said, I'm a board-certified obstetrician gynecologist. I worked for 20 years in private practice near Pittsburgh, Pennsylvania. And as you mentioned, in the last year or so, I've been working with Reasons to Believe, volunteering as a fellow, working on looking into the research on the transgender issue. This is an important issue. And as physicians, as scientists, we want to know, what does the data show? What is the truth? What is the evidence show? And so my team and I have been doing a deep dive into that recently.
Yeah, I really appreciate you doing that. Thanks. And by the way, Chris, this is not your first time on Stars, Cells, and God. You've been on the show at least 2 other times that I can think of, maybe more than that, where you talked about I think chemical abortions, and then you also talked about the reversal of chemical abortion agents.
That's correct.
Yeah, so I would encourage people to check out those episodes. They were excellent, and I'm looking forward to our conversation today, Chris. Let's start with some basics. What does the term transgender mean, and then what is gender dysphoria? We hear that term a lot. As a medical doctor, help us understand what those terms mean.
Yeah, that is a great question. We hear these terms all the time. The term transgender is a umbrella term that is typically used to describe someone or to self-describe someone who would say they choose a gender identity different than their birth sex. And this does not necessarily include what we call gender transition. It may or may not. So transgender is something, self-identification, whereas gender dysphoria is actually a diagnosis. There is an important psychiatric book called the DSM, Diagnostic Statistical Manual of Mental Health Disorders. And it's kind of like the Bible for psychiatry. And the term has been changed, but currently the term is gender dysphoria. So that is, as I said, is a diagnosis, and there's certain criteria. And in general, it means that someone has a marked incongruence between their expressed gender and their birth sex of at least 6 months. And it's distressing. And then there's a list of criteria that they would meet at least 2 of those other criteria to meet the criteria for the diagnosis of gender dysphoria.
Yeah. Okay. That's helpful. And then, when we talk about this whole idea of, gender dysphoria, there is an approach that the medical community is taking known as gender-affirming care. So what does that term mean? And then we're going to talk about, maybe we could talk about in general terms, what are some of the steps that are associated with gender-affirming care?
That's a great question. So gender-affirming care, sometimes it's called gender-affirming healthcare, in generally refers to the process of recognizing or affirming the transgender person in their gender identity, whether that's socially or medically or legally or behaviorally or some combination. So that means if a young boy says, I'm a girl, then the clinician affirms that identification. And unfortunately, often in gender affirming care, typically there is very little to no evaluation. So in gender affirming care, interestingly, it's the patient who makes the diagnosis, not the physician.
Right. And so there are a number of steps that are involved in providing gender affirming care. One of them deals with, is it social transitioning? That's like the first step. Then, and what does that involve? And then what are some of the other subsequent steps?
Right. So we kind of think sometimes of 4 steps, or social transition, puberty blockers, cross-sex hormones, and surgery. And some people do some of those steps. Some of them do all of them. Some of them do none of them. So I want to go through those. But first I want to say, we're going to get into some technical medical stuff. And I just want to say at the outset that, this is such a hot issue, but I want to recognize these are people who are struggling. And I want to recognize that. That's why this is such an important issue. In my research, I have not found there to be evidence to support gender-affirming care or many of these treatments. But we still want to recognize that these are people who are struggling with their gender or with other issues, and we want to recognize that. So could I show some slides here?
Yeah, you sure can. And I really appreciate that point, Chris, while you're getting your slides ready, because, to echo what you said, at Reasons to Believe, we take the view that every human being bears God's image, and therefore every human being is sacred. And so we want to make sure that when we do see people that are struggling with this very real issue of, their gender, that we are responding with a high degree of compassion and treating people that are struggling with these issues with the highest degree of dignity and value and worth that we can provide them. But that also includes making sure that the information that they have when it comes to gender-affirming care is actually the best information that they can have, so that they can make informed decisions, understanding really the consequences of each of these different steps in medical treatment.
So social transition is when someone wears the clothes or pronouns or name or haircut, whatever, of the opposite sex or the opposite gender or whatever gender they choose to be. For example, a girl who identifies as a boy may wear short hair and masculine clothes and go by a male name. And that's what's called social transition. This is to be differentiated from gender atypical behavior. So just because a girl likes playing with trucks or a boy likes playing with dolls, it doesn't make them transgender. That doesn't mean that that's not social transition. We all have a range of behaviors. If someone's good at math, a girl's good at math, it doesn't make them a boy. Or if a boy likes playing with dolls, it doesn't make him a girl. But when someone chooses to take on those characteristics of the opposite sex, that's what's typically called social transition. And we see this in young people is typically what we think of that as, although other people as well. But social transition is sometimes touted as reversible. And although logistically it is, the girl could, or the boy, whatever, could change those things, it can be very, very difficult, especially for a young person who maybe has lived as a young girl who's lived as a boy for 2 years to then revert, in social circles, that would be very difficult. And so we see that often social transition sets people on a path and the other thing that people do with social transition is, girls do chest binding and boys do tucking. And so they're hiding or accentuating body parts to look like the other sex. So that is social transition. And then often the next step would be puberty blockers. So I'd like to share some slides if I could.
Yes, please.
Puberty blockers is a medicine that young people take to stop the normal process of puberty. So before I talk about that, let me just explain normal puberty. So in normal puberty, the hypothalamus in the brain releases something called gonadotropin releasing hormone, which causes the pituitary gland to release luteinizing hormone and follicle stimulating hormone. And then in girls, that causes the ovaries to produce estrogen. And in boys, causes the testicles to produce testosterone. And there's a negative feedback loop where when there's a certain level of estrogen or progesterone or testosterone, it'll be a negative feedback on that system. So what puberty blockers do is they block that process, typically called medicine called leuprolide acetate. So what it does, it blocks the gonadotropin releasing hormone. So it blocks the process. So young girls, when they start taking this at 9 or 10, then don't produce estrogen. So they don't develop breasts or pubic hair. Young boys, it blocks the testosterone. So they don't develop a deep voice and a beard. So it's blocking the normal process of puberty. They block the GnRH, which blocks LH and FSH, suppresses estrogen and testosterone, and blocks the development of puberty. Now, this medicine called Lupron is approved in the United States only for the treatment of endometriosis and fibroids in women, prostate cancer in men, and precocious puberty in children. So this is when children start going through puberty at 4 or 5 or 6. And people have used this to say, well, see, it works in precocious puberty, but that's comparing apples and oranges, because in precocious puberty, Lupron is given for a temporary period of time to stop an abnormal process to allow the normal process to take place. And it's given until the normal time of puberty. And whereas when you're using puberty blockers in gender transition, it's blocking a normal process. And there's lots of side effects, menopausal symptoms, hot flashes, night sweats, vaginal atrophy and dryness, headaches. There's emotional symptoms, weight changes, nausea and vomiting, decreased libido, dizziness. These medicines, Lupron, I've prescribed many times for women for fibroids and endometriosis, and we only prescribe it typically for 6 months. It's a temporary measure because of the significant side effects. So I imagine I'm giving this to a 45-year-old woman, and she will tell me how terrible these hot flashes and night sweats are. If this is what we're giving to children.
So, these side effects, obviously are serious and significant, but, are there more adverse long-term health effects with using puberty blockers?
Yes, well, good lead in. So yes, I kind of talked about the immediate side effects, but we have some serious longer term effects, bone loss. I mean, puberty is a time of bone growth. We're stopping that process. Puberty blockers can cause sexual dysfunction and sterility. It can cause something called idiopathic intracranial hypertension, which is an increased blood pressure in the head, seizures. And there's so much we don't know. We don't know the effect that these puberty blockers are having on brain development in young people whose brains are still developing. And they're often touted as reversible and buying time. Oh, we'll just start the puberty blocker, then this gives your child more time to work this out. But that's really not the case, because what has been found is that almost all of the time when a child starts puberty blockers, they go on to cross-sex hormones. So then we're talking a young girl taking testosterone and a boy taking estrogen. So I want to talk about what we call the Dutch protocol. This is where where did this all start? I think for some of us, it's like this, you barely heard about it till a few years ago. Now it's very commonly out there. So the idea of blocking puberty for adolescents with cross-gender identity was introduced by the Dutch in 1996. And they published a paper then 10 years later with preliminary results in 21 patients. And then in 2011 and 2014, they published results of 70 patients. And those studies of just 70 patients, one actually was only 55 patients, are the basis for what's being done today. And again, they were claimed as fully reversible and buying time. Well, the Dutch protocol, this study, they took 70 young people, and this was the first study in 2011, and they evaluated the psychological effect of puberty blockers over 2 years. Now, they were eligible if their gender dysphoria, at that time it was called gender identity disorder, was diagnosed and persistent since childhood, if they lived in a supportive environment, and if they had no serious comorbid psychological disorder that could interfere with assessment. This is important because today puberty blockers are often given to kids with rapid onset gender dysphoria, who may or may not live in a supportive environment and who may have serious comorbid psychological disorders. So that's an important issue. So what happened? Well, this study by DeVries, they found that puberty blockers improved behavioral and emotional problems, they've improved depression, and they improved general functioning. But there was no change in anger, anxiety, gender dysphoria, or body dysmorphia. Again, however, the patients were regularly seen by a psychiatrist or psychologist, so they received both psychotherapy and puberty blockers. This was not a controlled trial. We'd had no control group. So which one helped? The puberty blockers or the psychotherapy? Plus, it was a small study with patients that are a different type of patients than those today often receiving the puberty blockers. Well, then in 2014, DeVries et al. Published the second major paper on this, and they looked at the longer term outcome in that group of people, the same 70 people. Well, they looked at 55 of them. So they assessed the patients before puberty blockers, before cross-sex hormones, and then 1 or more years after surgery. And they looked at their psychological functioning and their objective and subjective well-being. What did they find? Well, they found that in young adulthood, the gender dysphoria was alleviated and the psychological functioning had steadily improved, similar to or better than their same age peers in the general population. Well, when we look at this study, we have to realize that 15 of the 70 were excluded. 6 were not yet a year post-surgery. 2 refused. 2 didn't return the questionnaires. 2 were medically ineligible because of uncontrolled diabetes or morbid obesity. 1 dropped out, and tragically, 1 young person died from surgery, a vaginoplasty, so trying to make a pseudo-vagina. Person died. Out of 70 people, it's just incomprehensible that this will be held up as the basis for puberty blockers when we have a young adult who died, 1 out of 70 who died. So this forms the foundation of youth gender transition. So as I said, this really, why isn't this valid for today? Well, again, there's no control group. What would have happened if there was no intervention? I think of young people, I think of myself when I was 14 versus 20. Well, yeah, I'm a lot better off. We're all a lot better off after we grow up and get out of puberty. So what would have happened if there was no intervention? Plus, they received psychotherapy and the hormones. So which one worked? And as I mentioned, it's a different population. These young people in the Dutch protocol had gender dysphoria since childhood. And yet, even so, does this justify the adverse effects, including certainty of sterility, including one death, and as I said, the 15 out of 70 that were excluded from the study? So again, we kind of, I mentioned social transition. Often people go on to the puberty blockers, and then we'll take the cross-sex hormones and then gender-affirming surgery.
So, Chris, I mean, are puberty blockers reversible? Right. I mean, that's the claim, right? That this is again can be reversed.
That is the claim. Now, logistically, you could stop them, and the person should resume their normal puberty. However, studies have consistently shown that a large majority of those who start puberty blockers go on to cross-sex hormones. Plus, some of the side effects are not reversible. For example, if the bone loss and the brain effects, we don't have a lot of good data on this. So unfortunately, it's a path that typically most people continue on.
So there haven't been additional studies beyond these 3 papers published by this Dutch team that.
Oh, sure, there have been studies, plenty of studies. These results actually haven't been replicated. So, and there's no randomized controlled trials. The gold standard of studies haven't been done. We don't have long-term. We have very little long-term data. Most of the studies are low quality. So we're, as a physician, we're always taught, and it's my desire, always first do no harm. And we don't have the data to say that these are helping, but they clearly have some very significant harmful effects.
Well, that's a bit disconcerting to me that the results of this study haven't really been replicated, right? Given that it was such a small number of patients that were included in the study, and the fact that there weren't controls, you would think that there would be a very strong push towards, doing much more definitive work before this becomes something that's justified in terms of widespread medical use, right?
Yes, I would agree with you wholeheartedly.
So, are there other examples in medicine where this approach is taken, where you have really a limited amount of clinical data or even preclinical data that's used to justify some kind of treatment? Is this anomalous, or is this par for the course in medicine?
Well, that's a good question. I think about the thalidomide that was given back, 50, 60 years ago or so to women when they were pregnant, and to manage some of their side effects. And it was found to cause limb defects in the children, all these little children with no arms or hands. And, we have to be careful. Again, if medicines are powerful and intervention is powerful, it's better to not intervene than to intervene when we don't know if it's going to help.
Yeah.
And what I see with these is that children and young people, again, with gender-affirming care, often the parent may bring their child to a psychiatrist, and their child's troubled. They come home and say, I'm transgender. And, this needs to be addressed, but there's often many underlying issues underlying that. And so a parent who takes their child to a gender clinic would expect a full evaluation, or if they take them to a psychologist or psychiatrist, they would expect an in-depth evaluation. But in gender affirming care, the young person can get puberty blockers and hormones in one visit. And that's not good medicine. That's not taking good care of people. So, I think it's just unfortunate. People are being harmed.
Now, I'm seeing news reports about certain European countries essentially banning or, stopping stopping gender affirming care, at least for, people that are, adolescents, right? And is that the case? What's going on there? And then why isn't something like that happening here in the U.S.?
Well, you're exactly right. And so what we're seeing many European countries are, they're looking at this data. And so we have, Finland, Sweden, France, the UK, even Denmark and Norway and or Netherlands. So even the people that published the Dutch protocol are pulling back and either exhibiting more caution, or some countries are saying psychotherapy should be the first line of treatment, not puberty blockers and hormones, because they're seeing that the evidence isn't there. There was I think it was last year, an opinion piece in the Wall Street Journal, published by, I think it was 21 researchers in 9 countries. These were researchers and clinicians who worked in gender affirming care in multiple different countries, saying we need to have more caution. This is not the way to go. And there was no one from the United States who signed that article. I think, I hope the tide will turn. I fear that people will be harmed in the process before we turn it and see what's right for these kids.
All right. Well, let's spend a little bit of time talking about cross-sex hormones before we wrap up this episode, because as you were saying, the next step in gender affirming care, once puberty blockers are administered, is to then administer hormones to the patient. So if it's a female that wants to transition to be a male, they're given testosterone. If it's a male that wants to transition to a female, they're given estrogen. Is this usually done, in conjunction, or is it a sequential administering of the drugs? And what's going on with this particular aspect of the treatment?
Yes. So the young person, as I said, they may take the puberty blockers. Now, if someone's already gone through their normal puberty, they wouldn't take puberty blockers because they already have the secondary sex characteristics. So say we have a young girl who wants to be a boy, so she's taken puberty blockers so that she won't develop breasts and won't develop the body features of a woman. And she takes testosterone to appear like a boy. She's going to get facial and body hair, a deepened voice, fat redistribution, increased sex drive, clitoral enlargement. Often her menstrual periods will stop. Likewise, in a young boy who takes estrogen, or really any age, they're going to get a female fat distribution, decreased sex drive, sexual dysfunction, decreased body hair, sometimes breast tissue growth. So, and when you talk about reversibility, I mean, you could stop these hormones, but these aren't reversible. You can't reverse the effects of what's happened from these hormones. And I will go to the next slide here. And these have significant adverse effects. So testosterone, we're talking coronary artery disease, cerebrovascular disease, liver dysfunction, increased red blood cell concentration, high blood pressure, adverse effects on cholesterol and lipids. In estrogen, estrogen is associated with breast cancer. It's associated with clots, thromboembolic disease. So that's a clot in the leg or the lung, coronary artery disease, cerebrovascular disease, benign pituitary tumors, gallstones, high triglycerides. These are significant adverse effects
So,
I want
so
to
let
point
me
out
ask you this, Chris. So these would be adverse effects, not just simply in adolescents who are taking them in conjunction with puberty blockers. This would be adverse effects for anyone that was being administered these hormones used as cross-sex hormones.
correct. Yes. So if somebody who's post-puberty, a 25-year-old starts taking cross-sex hormones, yes, they would have these effects, or could have these effects. These are serious, significant adverse effects from these medicines. They're not without risk.
I mean, because
And
we're familiar with, professional male athletes who will take testosterone or some kind of testosterone derivative to enhance
right.
their strength and things like that, to increase their muscle mass. Are these comparable side effects that you're seeing in a male that takes excessive testosterone or in a female that takes excessive estrogen?
Well, the problem is you're taking the cross-sex. I don't think women typically take I mean, we do hormone replacement therapy in postmenopausal women
Right.
as their hormone levels have dropped. But a male athlete who's taken extra testosterone is going to bulk up, and so yeah, a girl taking testosterone is going to have increased muscle mass, and I mean they end up often looking like a male, which is what they want.
Right. But it would be similar side effects in either case then.
Yes,
Okay.
that's correct. Yes. So I want to show you just, I'm going to share my screen again here. So, the endocrine, this is a quote from the Endocrine Society. So the guidelines, so to speak, or standard of care for these is the World Professional Association for Transgender Health, WPATH, and we could talk about that. They've been exposed with a leak recently, but also the Endocrine Society clinical practice guidelines. So these are people that endorse these cross-sex hormones and puberty blockers. But all throughout their documents, they talk about the limited and low quality of the research. So this is from the Endocrine Society. Future research is needed to ascertain the potential harm of hormonal therapies. So this should not be done except in a clinical trial, but that's not what's happening.
Yeah. So, I mean, it seems to me like the bottom line here is that when you start messing around with hormone production or you start administering hormones, you really are, I think, playing with a loaded gun, right? These are such powerful biomolecules in terms of their wide range body effects. It just seems to me, honestly, as a biochemist, to be rather naive to think you can just block, hormone production or you can administer hormones and they're not being far-ranging effects, many of which may be beyond what you would desire, that you would want. It just seems a rather frankly naive approach to medicine to just view manipulation of hormones in such simplistic terms.
Right. And another way to look at it is in medicine, we would typically try the least invasive or least risky treatment. For example, if you have hip pain and you're thinking, I might need a hip replacement, well, they're usually going to try you on physical therapy first or injections before they go to the surgery. I mean, that's just an example. And yet these kids, instead of giving them psychotherapy and working through the issues, there are a lot of underlying issues in these young adolescents often. They're being offered these puberty blockers and hormones as something that's going to solve their problem. And, we don't know what percent of young people detransition, but there are certainly enough that show us that there are many people that regret this.
Right.
And it's a harder way back.
Yeah. Yeah. Chris, any final words before we bring this episode to a close?
Thank you for having me. And I just want to say, I want to go back to what I said at the beginning. A lot of technical stuff and medical stuff, but these are people, and each person is that we're talking about that's going to get a young person going for cross-sex hormones or puberty blockers is struggling, and we want the best for them. And there's not adequate research or to show in any way that this is the right thing for them. And so I just want to express, here, you and I, Fuzz, see each person is made in the image of God. And I just want to reiterate that.
Yeah. Well, Chris, thanks for being with us. And I'm sure we'll have you back to talk about other aspects of gender identity and particularly continue to discuss different aspects of gender-affirming care and the risks and the rewards associated with that. So again, very much appreciate you being on the show and also your leadership with this gender identity project. And I just want to remind all of you who are watching this, if you're interested in offering your thoughts, please make use of the comment section on the YouTube video to let us know what you think and maybe what other issues that you would be interested in seeing us address when it comes to gender identity. And I just want to say also that if you want to know more about Reasons to Believe and the work we do, go to our website, reasons.org. You can follow us on social media, RTB_official. Make sure you subscribe to our YouTube channel, Reasons to Believe. And remember that the more we know about science, the more we have reasons to believe. Until next time, take care.